Intimate Judaism deals with sensitive topics and uses explicit language. Listener discretion is advised. Welcome to Intimate Judaism. I'm Rabbi Scott Kahn.
And I'm Talli Rosenbaum, and we're here today with part 2 of our series on reproductive health and halacha with our special guest, Dr. Elissa Hellman. Before we begin, I would like to, first of all, say thank you to all of the listeners who wrote in with comments and feedback on part 1. One correction I'd like to make in the name of my friend Michal Schonbrun. You had brought up the rhythm method and asked me if it was the same thing as the fertility awareness method, and I said that they were similar, but in fact I did not point out the differences. And the differences are that the rhythm method is really a calculation-based method for predicting fertile days based on the length of cycle, whereas the fertility awareness method is an observational method, which is based on charting the fertility signs, like we said, the basal temperature, the cervical secretions, and the cervical position in real time. So it's much less of a calculation method and much more of an actually body knowledge-based method. Mm-hmm. So that's one thing I wanted to say. The other thing I wanted to say is that in our show notes, we are going to have a link to an article written by Michal Schonbrun on the various methods of birth control, kind of like what we're going to be talking about today, with a list of the side effects, including the sexual side effects. So, Scott, what are we doing today?
Last time, Talli, we spoke, obviously, as our listeners know, episode 37, about birth control, family planning in a general sense. Today, we're going to be speaking more specifically about different methodologies that couples use in family planning and birth control. We'll get to all that in just a moment. First, remember to check out our website, intimatejudaism.com, for the full podcast archive, show notes, a free men's mikvah list, and more. Intimate Judaism has helped many people better understand how intimacy relates to Torah Judaism and how Torah Judaism relates to intimacy. Because you have shared this podcast, we've been growing significantly and expanding our audience. Please help us continue to get the word out further by sharing on Facebook, Twitter, Instagram, or word of mouth, whatever can enable more people to join the Intimate Judaism community. We also have an Intimate Judaism Patreon site. Patreon supporters get bonus material, episodes, merch, and more. And it's an opportunity for people who have benefited from this podcast to support our work. The Patreon link is in the description of this podcast, as well as in the show notes. Recently, we released a Patreon-only Q&A, which dealt with a range of important topics. So join Patreon and gain access to that and more. And by the way, we will be doing an Intimate Judaism question and answer session on the main podcast soon as well. So please send us your questions to intimatejudaism@jewishcoffeehouse.com. Also, make sure to visit jewishcoffeehouse.com and tallirosenbaum.com. That's Talli with 2 L's, rosenbaum.com. Okay, Talli. Perhaps we'll start off by your introducing the basic methods of birth control. Then I'll speak a little bit about the halachic attitude that most poskim have towards them, and then we can bring on our guest.
Okay, that sounds great. I do want to say that, like I said in the first episode, reproductive health isn't only about birth control. It's also about how the different methods of contraception work together with other factors of being a woman, including mood and other aspects of the self. And so this will be true throughout the childbearing years, as well as perimenopause. I don't want to forget to talk about how perimenopause has a whole host of other considerations.
Can you define perimenopause?
You know what? I'll leave that to Dr. Hellman to talk about in terms of explaining that. But I just want to put it out there because even from a halachic point of view, as well as from a medical or physiological point of view, and also from a psychosexual point of view, the choice of contraception is very, very important throughout the life cycle, including the childbearing years, but also going into perimenopause, which is the period before actual menopause, where there's the actual cessation of the menstrual cycle. So what we know about the different birth control methods, and like we talked about before, these methods all have some advantages and all have some disadvantages, and many of them have sexual advantages and disadvantages, which is what we want to be able to talk about, and also how it affects both partners. We know that there are hormonal methods that are hormones that you take. There are some hormones that you put in the vagina. And there are, of course, hormonal IUDs, an IUD being an intrauterine device. There are intrauterine devices without hormones, and there are many different types that I'm hoping that Dr. Hellman will talk about. There are the barrier methods like the diaphragms and the cervical caps, and those are often used together with spermicides. There are the natural methods like the fertility awareness method. Also, early withdrawal is considered to be a natural method. There are male contraceptives such as the withdrawal method or using condoms. And then there are, of course, the sterilization method. So we're bringing in all the methods, even though not all of them will exist on the same halachic plane of allowability. You'll go ahead and talk about that. Okay, so Rabbi Scott, let's hear from you.
Okay, so first of all, Talli, as listeners to our last episode know, any discussion about the halachic permissibility of the various methods of birth control is predicated on the assumption that halacha already allows birth control in that given situation. For more information about that, of course, listen to the last episode where we discussed in broad terms when halacha may or may not permit birth control. This is all assuming that halacha does allow birth control. So when I say this is allowed or not allowed, I mean in the context where birth control in general is permissible. Moreover, of course, as I always say, this is not psak. These are general outlines for you to understand. Speak to your halachic authority before deciding what to do. The 7 categories you mentioned are the 7 categories that I was looking at as well, broadly speaking. I'm going to go from least permissible, as I see it, to most permissible, according to most poskim, most halachic decisors. The first is sterilization. Sterilization for a man is a Torah violation. It is not allowed, and sterilization for a woman is a rabbinic violation, which also means it's not allowed. I'm not speaking about sterilization because of medical necessity. I'm talking about sterilization for the sake of birth control. Should there be a medical necessity, that is simply a different discussion, which I'm not talking about. But if it's done for the sake of birth control, then this is not allowed, like a vasectomy, for example, or tubal ligation. Another method is the withdrawal method, or coitus interruptus. That is a method which is mentioned in the Torah in Parsha Vayeshev with Er and Onan. We talked about it last time, the 2 sons of Yehuda who were killed, according to Chazal, for doing exactly this. Of course, what they did is not clear. This is also a narrative rather than a legal portion. However, Chazal in Masechet Yevamot and other places have seen this specifically as referring to a prohibition on withdrawing as a means to avoid pregnancy. So because of that, coitus interruptus is a method which should not be done. The third method is a barrier method for the man, like a condom. Now, before recording, I was prepared to say that all poskim that I know of prohibit the use of condoms because when somebody uses a condom, it is really a type of hotzat zera levatala, spilling seed in vain, and that's prohibited. However, Talli, you sent me an article in the Zohar Journal by somebody named Rabbi Shaul David Bochko. I hope I got his name correct. He argues in this article that there are times when a condom could be permitted, actually. And in support for his position, he actually cites the Achiezer, who apparently says the same. I did not look up the Achiezer in the original, so I don't know the situations where this would be allowed. But apparently my initial contention that all poskim say a condom is prohibited is not true. However, I can still say that the good majority of poskim do not allow the use of condoms. Now, somebody might ask, they've listened to previous episodes, and we've talked about the idea that if a couple, for the sake of their sexual enjoyment, wants to use other methods other than vaginal sex, like oral sex or anal sex, that's not considered, at least according to some opinions, to be a halachic problem. It's not considered spilling seed in vain. Why is this different? And the answer is largely because of the methodology as well as the motivation. Because it's used as a form of birth control, therefore, in this case, it would be a more serious problem. When they're doing, let's say, for example, non-vaginal intercourse for the sake of sexual pleasure, that's very, very different than doing it for the sake of avoiding pregnancy. Now, beyond that, is a method, for example, like a diaphragm or a cervical cap. That really depends on whom you ask, whether it's allowed or not. Some say that because it doesn't impede the sexual act in any way and the sperm isn't killed in any way, therefore it should be permitted, should birth control be permitted. Others say that because it prevents sperm from going all the way into the uterus, etc., it is not allowed. It is a form of hotzat zera levatala, spilling seed in vain. Once again, it depends on which authority you ask. Another method is spermicides. In general, it seems to me from my research that this is generally seen as more permissible than a diaphragm, but less permissible than other methods like an IUD or a birth control pill. The problem is that on the one hand, the sexual act is completely normal, nothing changes. On the other hand, because a spermicide literally kills the sperm, some say that is the definition of spilling seed in vain because you're killing the sperm. I should mention also that there are different types of spermicides, and it seems that there's some that are foams that actually prevent the sperm from going in. They're a barrier, and that would be more serious, a bigger problem than something like a suppository, which doesn't prevent the sperm from moving in, as I understand this. The other methods are an IUD, which doesn't impede the sperm in any meaningful way. It just prevents it, as I understand it, from being implanted in the uterine wall, and therefore this is considered a permissible form of birth control in the event that birth control is permitted. And finally, birth control pills, hormonal pills, are also really not invasive in terms of the sex act, in terms of the survival of the sperm, so to speak. And because of that, this is also considered a permissible method of birth control. Okay, that is my brief overview of halachic attitudes towards the major forms of birth control. And I certainly hope that I didn't make any major mistakes or errors in describing the medical realities of each one. But I guess Dr. Hellman will let me know if I did.
Okay, that's a great review. I mean, I think that we have a lot to talk about here, but I'd like to bring in Dr. Hellman.
Yes, it's a pleasure to have Dr. Elissa Hellman with us today. Dr. Hellman is an experienced, board-certified OBGYN. She received her medical degree from NYU School of Medicine and completed her residency at North Shore University Hospital in Long Island in OBGYN. Dr. Hellman has been in clinical practice for over 11 years in Milwaukee, Wisconsin. She is also the physician at the Confident Kallah, a telemedicine gynecology practice focused on the needs of Jewish women who observe Taharat HaMishpacha. Throughout her years as a clinician, she noticed a gap in women's health awareness and education. This developed into a special interest in patient education and being a resource for the Jewish community in relation to body awareness and women's preventative health, starting from a young age, which I can say very much dovetails with our goals here, Talli, on this podcast. Dr. Hellman, welcome to Intimate Judaism.
Hi, thanks so much for having me.
Thanks so much for being here. We should tell our listeners how we managed to find each other, or how I found you. I just loved your reels on Instagram. They were so cute. I am new to Instagram, and I'm just kind of trying to find my place there. And you're pretty popular on there, and you're on there a lot.
Well, I have a lot of fun on there. So I also found you on Instagram, and I'm glad I did. So thanks for having me.
Great. Thanks for being here. So what can you say so far about what you've heard from Rabbi Scott?
Yeah, so I'm excited to kind of go through all of the different types of birth controls. I did want to kind of mention, as we're talking about choosing a birth control and, thinking about how it fits both into your reproductive choice and your halachic necessities, I think it's also really important to think about, why do you want birth control? Like, what are your priorities in your life for choosing a type of birth control? And, like you said, especially in your last episode, that we don't use birth control just to prevent pregnancy, right? We're using it for so many other reasons, all having to do somewhat with reproduction, but also just a general women's life cycle. And we have to think about, what are our priorities? Do we want our periods to be lighter? Do we want our periods to be non-existent? Do we want our periods to be natural the way that they just normally come? Are we trying to prevent pregnancy? Absolutely. Are we trying to prevent pregnancy mostly? But hey, if it didn't work, like, that would still be okay if I got pregnant. So there's a lot of considerations that come into choosing a type of contraception, not only dealing with preventing pregnancy. When I talk to my own patients, that's one of the first things I ask is, like, what is your priority? Because not everything is going to work perfectly for everyone. So if you have already kind of framed it in your mind of, hey, what do I really want out of this? What's my main priority? Then sometimes you're willing to, I guess, accept or kind of understand that not what you choose is going to work for that priority, but may kind of cause either some annoyances or may not work perfectly for everything in your life that you want it to work for.
Okay, well, starting with hormonal contraception, it's kind of ironic because when the birth control pill first came out, it was almost like a symbol of feminism and freedom and reproductive autonomy. And today, many of the feminists or many of the women's health organizations are looking at the fact that women are put, so to speak, on hormonal contraception without really being told what's in them, what it does to them, what are the side effects, how it can harm them, how it can harm their libido, how it can harm their even vaginal secretions, and what it can do to them over time. This is true even for hormonal IUDs, which we really know very little about what systemic application they can have, even though they are meant to only affect the uterine lining. So I'm wondering what you have to say about it, given that a lot of religious women are going to choose hormonal methods specifically because it's a great way to avoid niddah. And I know women who have really very happily used the Mirena IUD for years and years and years and years, went straight from that into menopause in order to be able to avoid any kind of having to deal with niddah. And the question is, what might be the long-term health risks?
Right. So, getting back to the birth control pill part of it, I think there's a lot of irony in how, right, in the 60s when birth control pills first came out, right, everyone was just so happy to have that choice, which is something they never had before. The 60s and 70s was also a time that it was a very different medical environment than we have now, right? With informed consent and looking at the patient as a consumer and understanding, like, what am I actually taking? I'm not just listening to these doctors because they told me this is my only option. I also get to kind of decide for myself too, and understanding the differences between options and the different actual medications that you're ingesting. So I think that has a lot to do with how we viewed birth control back then, which is like the only option we had, birth control pill, versus now when we actually have so many more options than we ever did, and then put that choice into the consumer or patient's hands, it becomes a little bit more overwhelming. So that's why I think it's great. And thank you for having me here today to kind of talk about all the different options. When I talk about birth control, I do like to kind of make sure that people understand it in categories, right? So going from the pill to the IUD, to the rhythm method, to the condoms, to sterilization, to Nexplanon, there's so many different ways to kind of talk about them and think about them. But if we categorize them, it kind of makes it a little bit easier to understand. So, and I'll kind of just jump right in with the way that I kind of organize them. So I like to think of it as three main types of contraception. One is non-hormonal, right? And in this category, we have the permanent sterilization, both for men and women, vasectomy and tubal ligation, meaning tying the tubes. We have condom use, we have diaphragm, we have spermicide, and we have that whole group of fertility awareness or rhythm method, or just being more aware of what your body is going through in different ways to avoid sperm and egg from meeting. Number two, progesterone only. So this is where we start adding in hormones. Progesterone and estrogen are the two hormones that we use in contraception and cycle control. Progesterone alone is one way to do it, and that includes a few different IUDs, Mirena, Kyleena, Skyla, Lolita, and Nexplanon, which is an arm insert. It goes right under the skin, and a progesterone injection, which is a shot called Depo-Provera, and a progesterone-only pill. Then we move on to estrogen and progesterone combined. Estrogen and progesterone combined would be a birth control pill, a NuvaRing or Anovare, which are vaginal rings, and a patch. It's a patch that has both estrogen and progesterone. So first, it's nice to kind of think about, well, what are my goals? What do I want to do with my periods? What do I want for my birth control? How long do I want birth control for? And then once you make that decision and decide which category is best, to then pick the method of getting that hormone or a non-hormonal method within that category that you've kind of decided is right for you and your priorities. Well, let's start with the pill. One thing that I really want to stress with the combined birth control pill is there is not just one pill. There's not two pills. There's not three pills. There's like 50 pills. There are so many different types. So when someone says, birth control pills don't work for me. Well, how many did you try, right? Like, did you give it a chance to see what worked for you, what didn't work for you? There's two hormones in a regular birth control pill, estrogen and progesterone. Most of the pills, all the pills that are differ by dose of estrogen and type of progesterone and dose of those types of progesterone. So you can do so much with, if someone has a little side effect from birth control pills, change it up, drop your estrogen up your estrogen, change your progesterone, change the dose of progesterone, and kind of work within what you think is working for you. But I have a little side effect. Let's try to fix that by changing one variable so that you can kind of organize where you may be getting your side effects from. And what combined birth control does is it allows you to very easily manipulate the cycle. So when a woman is put on a combined birth control, what that is doing is it's preventing ovulation. So that egg never pops out of the ovary. And no matter how many times she has sex, that sperm and egg never meet because there is no egg. And then when a woman stops taking it, there is a withdrawal bleed, which is like a period. And it's structured in that you would do that every 4 weeks to mimic more of a regular cycle where a woman would get a period about every 4 weeks. You don't have to get that period, though, every 4 weeks or that withdrawal bleed. You can just continue taking the hormone pills instead of the inactive pills, or the inactive week when you're off your NuvaRing or off the patch, and not get a period. Now, that doesn't work perfectly for everyone, and that is also a really big point I want to stress. All these different ways of kind of manipulating and controlling a cycle doesn't always work perfectly for everyone. But like the general theory of it, that's how it works to help control a cycle. So if someone's going on vacation or you're planning your wedding or you just like don't want to have your period at a certain week, okay, you can try to push it off or move it around because you're not really getting a period anymore. It's just a withdrawal bleed that you are kind of in control of.
You said that they don't have to get that withdrawal bleed. Is there a reason that they would want to?
The main reason that I would recommend taking that withdrawal bleed, like giving yourself a break, is if you start having spotting. So sometimes your body's like, I've been on this pill for 9 weeks, 10 weeks, 11 weeks, and that uterine lining has built up enough that it's starting to come out. Like you're starting to see some brownish or pinkish. Whether that puts you into niddah or not, of course, you would have to ask the shaila from your halachic authority. But if it's kind of a sign that, okay, things are starting to come out on its own, let me take that break and let me just make a controlled bleed, get like the 5-day period, and then go back to it. And then I can continue again as long as I want or until that spotting starts again. But there's no medical necessity for having that withdrawal bleed or that period while you're on birth control. That's called continuous birth control. And some women are on it for years without taking that placebo week and not getting a period.
Mm-hmm. Interesting.
Yeah. And different pills with different progesterones work better to prolong that time frame that you don't get any spotting or period, and that just has to do with like specific doses and types of progesterone that sometimes work better than others for different people.
So I'm just going to jump in, if it's okay, to kind of look at this a little bit broader in terms of the advantages, obviously, of having far longer periods of time to be together and not have to observe the halacha code and not being able to touch and not being able to have any sort of physical intimacy. And yet, how do we kind of balance that with what we know scientifically to be true? And you talked about how there are different doses and women can try different kind of combinations. But we do know that any sort of hormonal contraception, oral contraception, is going to affect free testosterone levels in the blood. That does have an effect on reducing libido. Most of them will contribute to some amount of vaginal dryness, and also the decreased testosterone over time can also cause shrinkage, just like in the menopausal period. So it's certainly something that many, many women who are being given birth control pills who don't necessarily ask about these particular sexual side effects may be having without even necessarily knowing that they may be because of the pill. And one other thing I want to say, we did an entire episode on sexual pain disorders. And we know sexual pain disorders to be pretty common. The statistics vary between 8 to 20% of women will have some kind of sexual pain issue, whether it's vulvodynia or vaginismus or some other type of genitopelvic pain issue, which many of the experts in the vulvar health experts are looking at, not using birth control or oral contraceptives, because of their effect on the vagina, that it actually does thin or even cause some amount of atrophy of the tissue. And, I'm just wondering, you're a gynecologist, women come to you. Are you telling women these things, or do you feel like many doctors that, you don't want to plant things in their head that that they might come back with later that they wouldn't have necessarily thought of? I'm curious as to how you talk about potential sexual side effects. Or when women come in with sexual pain disorders, might you take them off or recommend that they go off of oral contraceptives?
Yeah, so I hope that I'm complete in my counseling when putting someone on a birth control pill. And I think we also have to understand, like, birth control pills are medication, right? Like, it's the medication just like any other. Like, you have high blood pressure, you have thyroid disease or something, you have to go on medication, right, for a reason. Here are the side effects, but we're also like, here's our goal of treatment, right? So, definitely doctors should be counseling their patients whenever they write a prescription for anything about what, the side effects and the benefits are of whatever they're putting them on. Now, as far as birth control pills go, as related to sexual side effects, like I said before, there's a lot of different types of progesterones, and they're kind of quantified or categorized in different like generations of progesterones. Right now, we have about 4 generations of progesterones, and the older ones actually have a lot less sexual side effects, and the newer ones have a little bit more of those sexual side effects. And yes, all of those progesterones are what's called anti-androgenic, which is like kind of that anti-testosterone, making those lower, the testosterone levels lower, which, yes, the side effects are vaginal dryness, pain with insertion, decreased libido. Most of the time, they don't, once you take someone off of it or switch the progesterone, they notice somewhat of an improvement in those sexual side effects. Not always. Sometimes there can be, especially if it's like a tissue effect with pain or discomfort, there can be somewhat longer lasting effects of those. And it takes more time to kind of wash that out and your hormone levels to kind of get back to normal in relation to testosterone production. I should make a note that once you stop taking birth control, your fertility, whatever your fertility is back, right? So the fertility effect or the infertility effect of birth control goes away once you stop it. But there can be some of these non-contraceptive effects that do linger with, for a few months or so after stopping a specific type of hormone. So yes, if someone were to come to me saying, hey, like I have no sex drive, decreased libido, it kind of hurts, it feels dry, like we've tried lubrication, but that's not super helpful, okay, what pill are you on? Are you on what, or any type of birth control, you want to switch it. The only way to know is to really see, right? So we have to kind of work on the schedule of switching it, right? Sometimes you can't just stop and start something. You have to make sure, if you don't want to get pregnant, right? We have to make sure we're doing this properly so that there's no break in contraceptive coverage. But yeah, the only way to know is trial and error, because some women do great on one hormone and others don't do well at all on them. So it's so individualized as to who has side effects on which specific hormone we're talking about.
Would you recommend to a woman, for example, who does not have children yet and is not managing with hormonal contraception because she has too many side effects, and because she has sexual pain, let's say, can't really manage a barrier method, and this might be a situation where probably the best option, which would cause the least friction, and literally as well as figuratively in the relationship, would be a condom. The question of using a condom for the purpose of birth control when all of these other methods may not be appropriate. Elissa, is this something that you have ever worked with? And also, Rabbi Scott, what can you say about the possibility of allowing something like that?
Well, I'll tell you that, in birth control counseling discussions, right, it's definitely important to take the whole woman's life into account. And so I'll tell you that in my non-Jewish patients, condoms is definitely an option. Also, though, if someone is having pain or discomfort, especially near that vestibule or the introitus, which is really the opening of the vagina, and pain with penetration, we have to also make sure that if they were using condoms, like, is the material of it, not uncomfortable, and is there some type of like latex allergy or something that do they need to change their brand of condom? So we also have to kind of take that into consideration, try different things. Are they using lubrication also? Is that affecting the material of the condom? So that's important to think about. I'll tell you, with my Orthodox Jewish patients, I really don't use condoms as an option, because I think it's like Rabbi Kahn was saying, I really think that it's generally not allowed. And that's something that needs, of course, to be asked of your halachic authority. I generally find that people are not even comfortable with thinking about that as an option. People pretty much either know that condoms are not generally used in Orthodox Judaism, or they don't even know what it is because they've never been told about it.
But do you provide that counseling as a religious gynecologist with religious clientele? Do you present all the methods in the same way that you would present the methods to your non-Jewish clients, or do you do the filtering for them based on what's halachically acceptable?
I will try to be complete and mention every method. As far as the lengthy explanations of each one of them, I definitely go into more of them in the ones that are more generally halachically permissible. But I do like people to know what's out there in case down the road it is an option, or that's something that they have to ask about.
I think too, it's different in America than in Israel, because I think that if a religious woman is going to a religious gynecologist on purpose because she just wants to make sure that she's doing the right thing halachically, then that's what she's expecting of you. But there are a lot of women in Israel who just are going to a gynecologist. And if they happen to get a religious gynecologist who's only giving them the religiously approved birth control methods, then that could be considered to be a professional, ethical question. If that's not what they want to hear, they just want to hear, well, what are all the possible methods? Don't tell me what I'm allowed to use and what I'm not allowed to use.
I just want to second what Dr. Hellman said in terms of asking a question. It seems like the obvious point, but I think it's very important to mention. There's almost the flip side of my saying that, I'm not opposed to it. Part of it also is that there are many times that things that you think are prohibited may actually be permitted. I'm not talking about condoms per se, but it's always worth asking a question of your halachic authority, because it could be, and it's happened many times, that people assume that something is prohibited and therefore they might do damage to their sex lives or any other area of their lives, when in fact they should have asked a question and actually there was a way that they hadn't thought of that this could be permitted. Now, when discussing the issue of using condoms as a form of birth control, as I said earlier and as Dr. Hellman echoed now, the vast majority of poskim do not allow the use of condoms for birth control. By the way, I do want to mention, just as an aside, that I'm not talking about using condoms for health purposes, such as when one partner has HIV. I'm not saying it's allowed then either. I'm saying it's a completely different question which needs to be addressed separately. In any case, though, the good majority of poskim do not allow the use of condoms, but it's always worth asking a question, because it's very possible, as Talli pointed out earlier to me, there are some who do allow it, and perhaps your halachic authority will say in this context, something which you thought was prohibited may in fact be allowed. On the other hand, that does not mean that you can now say, I know that somebody permits it, so therefore I'm allowed to do it. That makes a total mockery of the entire halachic system. One has to know who allows it, what the context was, what the conditions are, whether that person is in the mainstream of halachic thought, etc., 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 which is why it's important not to just decide on your own what you're going to do, but rather ask a halachic authority, assuming that you care about following halacha. However, it's important to also realize that things are sometimes not what you expect them to be, whether the chumrah, whether the kula, whether on the strict side, whether on the lenient side.
I do have Jewish patients, not religious, who I know that they use condoms as their main method of contraception. And I view my job as a frum gynecologist to kind of decide, what am I in what context, right? Like, you're coming to me as a doctor, and I can give you all the options for contraception, even though you're happy using your condom. I say, okay, well, there's also this. But I don't feel like in the medical office, it is my role to say, oh, you can't use that. It's not halacha, right? That's not okay. Like, that's not for me to decide for each person. But if someone Orthodox is coming to me saying, so what are my options as an Orthodox woman? I can then say, well, these are the ones that are generally halachically permissible. These are the ones that aren't. So what do you want to talk about more, right? I tailor what I say based on who's sitting in front of me, right? Like that's really what matters.
Talli and I actually discussed something very similar a couple of episodes ago in talking about rabbis or yotzot halacha. How that person answers a question largely depends on what hat that person is supposed to be wearing at that time. Are they being asked a halachic question, a hashkafic question? Is it pastoral counseling? So I think a lot of us have that in our lives, that it's not only a matter of who we are, but which particular aspect of our job or our personality is being accessed at that point.
Okay, I'd like to ask another question. I have a few actually, because, I see these kinds of things in my practice. I often will have couples where the woman is really struggling with not being able to use oral contraceptives, not being able to manage with barrier methods. And there are no kids yet, and there are no plans to have kids anywhere in the near future. So what is your opinion on inserting an IUD in a nulliparous, which means a woman who has not had any children yet?
Right. So I'll say, when we say IUD, just like when we say the pill, there's a lot of different IUDs, and I think we can't just lump them all together. We have to pick the right one. I am fully supportive of putting an IUD in anyone who wants one. I have 15-year-old girls who I put IUDs in my regular practice, and better that than other things. So, when we talk about IUDs, there are two different types. One is non-hormonal, which is called, at least in America, it's called Paragard. It uses copper. I'll say in other parts of the world, there are other intrauterine devices that use copper that look a little bit different than the Paragard IUD. The Paragard is like a T shape. I know in Israel, and I learned this from Instagram from people, my followers, telling me there are it's like a string of copper balls that get inserted inside the uterus. No matter what shape it is, what the copper does is we think it creates an inflammatory reaction that affects the endometrium, or the lining of the uterus, that makes it very inhospitable to sperm. So it's like kind of like an indirect sperm killer. But basically the sperm, once it encounters that inflammation response within the uterus, they don't really make it to the fallopian tube, which is where fertilization would happen if there is an egg that was just ovulated within the day. So that is how the copper IUDs work. Now, copper IUDs, the main side effect of them is menstrual, where because we're causing that kind of irritation in the lining of the uterus, the periods themselves can sometimes last a little longer. They can be heavier and they can be crampier. I generally find with women who are observant and practicing Taharat HaMishpacha that longer cycle is somewhat frustrating, because it means that your niddah time is longer. So that's definitely something I would bring up in the counseling of it. If it's an extra day or two, it may not matter, and they may be totally fine with that. But just to kind of be aware, like, hey, this will impact a different part of your life. But there's no hormones, you're still on your regular cycle. If that works for you, great. Now, these usually last for 10 years. Again, they can be taken out at any time if you want to try and conceive, but that's usually how long they last for. Now, they're very different from the progesterone IUDs. Now, the progesterone IUDs, of which there are 4, all use the same progesterone, levonorgestrel, in different doses and for different timeframes. So I'd say the most popular one is Mirena. That was the first one to come out. That one lasts, actually for contraception, it lasts for 7 years, but it is also used, an actual indication is to help treat heavy periods. So even if someone has their tubes tied, or they're not even sexually active, they can use it as a treatment to help heavy periods. And why is that? So this is a direct opposite effect from a copper IUD, where long-term progesterone exposure to the uterus thins the lining of the uterus. So when it's period time, and you may feel premenstrual, right? To get PMSy, moods, cramps, breast tenderness, but then no bleeding, because there really isn't much of a lining there to bleed. So the progesterone IUDs work in many different ways for contraception. They thin the lining of your uterus so that it's not a great place for an embryo to implant. So a lot of people are worried, hey, wait, I'm conceiving if I'm ovulating, but then like my embryo was not able to implant. So that's actually one of the kind of more less used ways of contraception from the Mirena. The main way that it really works is that the progesterone thickens cervical mucus, so that sperm has a really hard time even getting into the uterus to then get to the egg that's in the fallopian tube. So that is the main way that it works. It also decreases the motility, like the movement of the fallopian tube, which helps bring the egg to the sperm. So if that doesn't move well, the egg and sperm also have a hard time meeting. The uterine mucus changes, the uterine lining thins. So there's a lot of different ways it's working for contraception. Now, the different progesterone IUDs differ by dose. So there's Kyleena, 5 years, lower dose. There is Skyla, 3 years, even lower dose. Lolita is a different IUD that's actually really just the same as Mirena, same dose, same hormone. So you just may find it in different offices or different countries. And they all work the same for contraception, but the changing in dose, the lowering of the dose will affect the uterine lining less, meaning the lower dose of your progesterone, the more regular period you may get because it's not thinning the lining in the same way. We also kind of tailor, well, what's important to you? Is do you still want to get a period? Some people really like seeing that monthly period. So they may choose a lower dose one. Some people are like, I don't want a period again. If I can get through and have a Mirena IUD in until I'm menopausal, great. I never want to see my period again. And of course, nothing is guaranteed. This is just, you have the highest chance of achieving that effect with a higher dose IUD like Mirena or Lolita. But those are all kind of the considerations that we talk about when talking about IUDs specifically. As far as insertion goes, you had asked about like, would I put one in someone who hasn't had a baby before? And I think the reasoning behind that question is it going to be uncomfortable? Will it even fit? And yes, it will. I mean, these are very, very small, skinny devices. You take some Advil or something beforehand to help with a little bit of cramping, but there's a hole in your cervix, right? That's where you get all your period blood flowing out of. It's there. You can get an IUD in. Here and there may be some anatomy differences that make it a little bit difficult in a specific woman, but generally anyone with a cervix and a uterus should be able to have an IUD placed in them.
Dr. Hellman, at the beginning of the show, you mentioned that some considerations include couples that don't want to get pregnant, but if they do, it's really okay. So when you mention that kind of contraception, I assume you're referring to something like a spermicide or a diaphragm, which, as I understand it, I want to make sure I'm understanding it properly, are less effective than an IUD or hormonal pills. And as I mentioned, also might be more halachically controversial, according to some, than an IUD or hormonal pills. Is that correct?
Yes, that's correct. So a lot of the non-hormonal methods outside of the Paragard IUD will be like the spermicide, diaphragm, even like the pull-out method, even condoms, and I'm going to lump it and say fertility awareness method, but that includes all the different types for the method. They're probably in the 80%-ish range of working, and each one varies a little bit differently. And each one really depends on the person and the couple using it, right? Like how diligent are they in it? And something that is like a hormonal IUD that is placed in you and there is zero compliance factor, right? It's in you. It's not like you're going to forget to take a pill. It's not like you're going to forget to put a condom on or put enough spermicide in. Those generally have a much higher contraceptive effectiveness rate, like in the high 90s, like way high 90s. And that's just due to why it works for birth control. There's a lot less human error potential in hormonal contraceptives you don't have to be responsible for them on a daily basis.
Is it also that the contraceptive itself, like a spermicide, simply is not as effective, even if you don't do anything wrong, don't make any mistakes, no human error involved, it just isn't always effective. Is that right? Or it's all based on human error?
Yeah. You're especially something like a spermicide specifically, right? Like the goal of spermicide is to kill all the sperm from one ejaculation. And you have to put it in a specific time frame before that ejaculation happens. So if you aren't perfect with the timing, or there happens to be more than one ejaculation, or the spermicide itself is old, like who knows what you have in your nightstand table, right? It's just not going to work as effectively. And there could be more potential of like sperm escaping that method of contraception, as opposed to something like an IUD where you're not changing your cervical mucus from day to day, right? Like that effect is there no matter how many times you're having sex.
And obviously, another variable there regarding effectiveness has to do with whether or not you're ovulating. So, when you pair your barrier methods with knowledge about your body, just kind of knowing your cycle, knowing your body. I mean, I think we talked about this in our first episode, that reproductive health is really also about whatever method you decide to use to prevent pregnancy. It's, really about using it together with a lot of awareness about your body. What we didn't talk about, of course, was the morning after pill and those methods that are what you use kind of as a b'diavad way to deal with and kind of an oops situation where I guess there was penetration and there wasn't any form of protection for whatever reason. I guess we would have to do another episode to talk about that, because people really would want to hear the options for when that occurs.
Yeah, the morning after pill is an interesting question and an important one, and we probably should do an episode on the morning after pill and other issues that come up post-conception. I have not done extensive research on this, but it does seem to me from what I have seen that the morning after pill question is really about birth control and not about abortion. In other words, it would not be considered, as far as I understand, an abortion for someone to take the morning after pill. Whether it's a permissible form of birth control is a different question, but it would not be an issue of abortion because generally we only see the embryo as having a type of life once 40 days have passed since conception. Before that, the embryo isn't really living, and because of that, the question is more one of birth control rather than of abortion.
Okay, so since we are running out of time, I'm wondering if you could talk about how you help patients manage the perimenopausal period, particularly as it relates to taharat mishpacha, because it is a very difficult period to navigate, where even if you spent most of your childbearing years with some sort of sense of knowledge and control about when you're going to menstruate, this suddenly goes awry.
Yeah, definitely. I wanted to, before I talk about that, I wanted to get back to something you said before, which is a really great segue to this, is when you're using something like a fertility awareness or rhythm method along with spermicide or diaphragm, it is helpful to have that really nice sense of cycle awareness to help you use it. And these can be 100% effective if you are regular in your cycle and you're very diligent about it, right? Just because I say 80%, that's overall with everyone using it. But when we start getting to the perimenopausal stage, and also applicable to people who don't have a very regular cycle, and it's really hard to predict when they're ovulating, we get into a very, very confusing and frustrating time in a woman's life. So perimenopause is really, I'd say, about 3 to 5 years before menopause. And menopause is defined by 1 full year of no periods. So if you go 9 months and you get a period, you're not menopausal yet. You're still in that perimenopausal time frame. Many, many things can happen during this time frame to women, and it's very, very individualized. So the two main things that really do affect, I'd say, a woman who does observe taharat hamishpacha is, number one, bleeding irregularities. And bleeding irregularities can be all over the place. You can have extra periods, less periods, heavier periods, longer periods, later periods, no periods, and you just have no clue what's going on. The reason for that is you ovulate less. The ovulation is not as regular because your uterus and your ovaries and your brain are not communicating as well as they were 10 years ago, 5 years ago, when you were getting regular cycles. So if your ovaries are not ovulating on a monthly regular basis, there's no good signaling to tell your uterus, okay, not pregnant, bleed the lining out and prepare for the next month for a potential pregnancy. So when that doesn't happen, the uterus continues in that same phase, building up that uterine lining, and then it's super thick, and then it just kind of randomly starts to come out, or you get an ovulation and you have this 2-week, 3-week long, horrible, annoying period. It's usually the extra bleeding due to what's called anovulatory cycles and longer bleeding that makes many women say, hey, I need to control my bleeding. Like, that is my number one priority. the chances of me getting pregnant are lower, right? Fertility definitely declines in this phase. Usually women are going through this in their mid to late 40s. Fertility, even though it is still possible to get pregnant at that time frame if you are ovulating, fertility itself is lower. So many women look for something to help control their bleeding so that they can still have a pretty normal sex life as far as timing goes. So an IUD, progesterone, is wonderful to kind of help with long-term treatment of this, right? This is a long-term issue. It's not going to go away in a few months. It may only get worse. It may get better, but it really may only get worse. And it's nice to have these long-term IUDs that are used to kind of carry a woman through menopause, right? When, hey, let's take it out. You're 53, 54, 55 now, take it out. Hopefully your periods are done and we don't have to worry about the bleeding aspect of it. So long-term progesterone is nice. It can be used for that. Some people just don't do well with the progesterone IUDs and they get a lot of spotting with it, which is one of the side effects of it. Many women don't have that, but it is a main side effect of a progesterone IUD. And if they're like, hey, I don't want to make my problem worse, so a regular birth control pill is also an option if you have not developed any other medical conditions that would not allow estrogen. So that's something that women can use to help control their cycle as well. And that kind of gets into well, what are some other side effects of perimenopause? And one of them is definitely sexual side effects, decrease in libido. As that estrogen level is going down naturally in your body, it can really affect the skin and tissues of both the vulva and the vagina, less lubrication, less elasticity, less thickness, and if sex is uncomfortable physically. So that's why it's very important to, if you're going to treat hormonally, pick something with the progesterone that has the least sexual side effects, and also be very aware of, okay, let's say I have a bleeding issue and a sexual side effect issue. I'm trying to treat my bleeding hormonally, but now I have these sexual side effects. What are other things I can do? What types of lubrication are going to be helpful for me? There's lots of different water-based and silicone-based and coconut oil, like little things that you may not have thought of, but your doctor should really hopefully be aware of them and kind of go over what we can do to help the problem. And at the end of the day, if the sexual side effects now surpass, the frustration of them now surpasses the bleeding aspect of it, then we have to change up the hormonal control of the periods and find something else, because we don't want to make one problem by fixing another. So that's kind of the general overview of a perimenopausal discussion when it comes to both contraception, perimenopausal side effects, and sexual side effects.
Yeah, so we see that there's an intersection with so many different areas, including sex and mood and bodily changes. I mean, it's a whole kind of experience of change and of also professional roles, sometimes role identity, becoming grandparents. I mean, there's a whole lot that can be connected to this period, which we could do a whole episode on. One thing I want to say, just from a halachic perspective regarding the Mirena, many women complain about not being able to get clean. And what one yoetz at halacha once told me was that if you put the Mirena in when you're already clean, and most gynecologists like to put in IUDs when the cervix is open during the period. But if you're clean and then you put the Mirena in, that the spotting that comes after that is not considered niddah spotting. And so that might be a good way to bypass the first several weeks of spotting that doesn't allow you to get a clean hefsek after you put in a Mirena. Have you heard that?
Yeah, so it's funny. I actually have two different IUD timing conversations with my patients. So if they observe mikvah, niddah, and taharas hamishpacha, what I generally like to do is put it in very soon after mikvah that month, because there can be that prolonged spotting, and I'd rather not mess up the sheva nakim, have them get to the mikvah, because any spotting that happens after may not be enough or considered a niddah status. So that is definitely what I would recommend. I liked it to be as close to the mikvah as possible, because as we get closer, right, 2 weeks later, she's going to get another period. So then we're getting to the point where that lining, right, that month of the uterus is getting thick, right? We're getting to the point where, hey, preparing for pregnancy, no pregnancy. Okay, now I'm going to get a period. And the thicker it is when we put the IUD in, the higher the chance that she's going to have more of a bleed from it. So that is why for my non-Jewish or non-Taharat HaMishpacha observant patients, I actually like to put it in right after the period is done, not caring so much about the cervix. So again, cervix as a whole, it's open, it's there. You can get an IUD and it doesn't have to be with a period. But if we put it in right when the period is done and that lining is the thinnest it's going to be that month, then there's usually less spotting just from the initial progesterone effect.
But enough to ruin the Shiva Nikiyim for those who keep Torah.
Right, and it may ruin the Shiva Nikiyim in someone who has to be totally clean. It can't have spotting on an internal white cloth, right? But generally there's less prolonged spotting, right? Like the length of time it's going to happen when we put it in when a full period has finished completely.
So I really think that the bottom line to this entire discussion is that there is no one size fits all, that there are many, many considerations when choosing methods of birth control, that we need to talk to our doctors and become educated, become informed. Obviously, where there are halachic considerations, to talk to halachic authorities as well. But the idea of just kind of going to a doctor and being put on birth control without any kind of discussion, that's something that hopefully is not going to happen too much anymore as women become more educated about the different options that are available, as couples become more educated.
Right. And I mean, if I can just say one thing at the end here, I think the most important thing, and it's somewhat selfish because it's so helpful for your doctor when they're taking your history and they're finding out what have you been on before. Don't just say the pill. There's no such thing as the pill. There's so many different types of pills. It's so helpful to know what dose were you on and write it down, keep it in your phone, your calendar, whatever, but write down your dose, write down the type of hormone, even if it's a big, long word you can't understand, because that really helps guide decisions for the future. If something what didn't work for you with these? Why would I give that to you again? But how do I know that's what you were on unless you don't know, right? Especially if you're changing doctors and records are hard to come by. So yes, definitely, I will totally echo that sentiment of know what you're taking, know your body, know your cycles. It will only help your doctor, will only help you really be able to make a decision that is right for you and your sex life.
And know your sexual side effects and know
Definitely.
your general side effects. I mean, you can love to have a barrier method, but they're not as spontaneous. And you can love to be on the pill, but if you forget taking your pills, that's not a great option for you either. And if you don't like to have long, drawn-out periods, then a non-hormonal IUD is not going to be a great option. I mean, everything is going to be really very, very individualized. There really is no perfect method. There's going to be advantages and disadvantages. And the most important thing is to have conversations together with your partner, have conversations with your healthcare provider, and learn about what's out there and learn about your body.
Definitely.
Dr. Elissa Hellman, thank you very much for joining us today on the podcast. We all learned a lot, and we'd like to have you back again soon because there's so much more to talk about. So thank you for joining us today.
Thank you so much for having me.
Thank you.
Remember to check out intimatejudaism.com for the full podcast archive, show notes, a free men's mikvah list, and more. Go to Intimate Judaism Patreon for free bonus episodes and merch. We will be doing an Intimate Judaism Q&A on the regular podcast, so please send your questions to intimatejudaism@jewishcoffeehouse.com. Visit tallirosenbaum.com and jewishcoffeehouse.com. Thanks for joining us.
Bye.